Obviously, I'm with the faculty at Wright State. And, my major jobs over there is complex reconstruction of the limb and joint arthroplasty, meaning hips, knees, ankles, occasionally shoulders, and even wrists, elbows. So no holds barred. But today's topic is on the hip, okay, because it's kind of hippie here. Seems like a strange title, huh? From the womb to the tomb, but maybe by the time we finish the talk, you'll kind of understand why I selected that. But everything, of course, has to start out with anatomy. And hip joint, first of all, very stable joint. It's a ball and socket joint, extremely difficult to dislocate. Basically, the articulation is the around femoral head, looks like a billiard ball, and the socket that matches it almost completely. The acetabulum is the socket, another name for the socket. It's not a complete circle. It's kind of got a horseshoe-shaped appearance, as you'll see. And then the proximal femur has a certain type of different anatomy to it, which allows the limbs to be straight, avoid the size of the pelvis and so forth. If it came straight down, it'd be kind of hard to walk. So this is kind of a diagrammatic picture from Frank Netter's book, who's probably one of the greatest artists for anatomy, especially orthopedic anatomy. But you can see the femoral head here is nice and round, and it should be about as round as you can possibly get. That's to be normal. And you see it fits into this socket over here, but that socket is not complete. There's an area right over here where there's kind of a, oops, that's interesting. So there's kind of an area here where there's actually a ligament. And there's another ligament here that attaches to the head. So there are some attachments there. And then in addition, there is a very fibrous structure that surrounds the entire acetabulum. It's like a suction seal. And that's very important for the lubrication of the hip joint. A normal hip joint can take loads up to 6,000 pounds, okay, of compressive loads. That's phenomenal. And still function without any problems. And this just shows the proximal femur. We see here that there's kind of an offset there. So like I said, it's a very stable joint, got a lot of ligaments, very strong ligaments. In fact, traumatic dislocation of the hip really takes a lot of force to occur. So there's a different anatomy to the proximal femur, which makes up the head part. And primarily that's where most of the differences occur. And hip movements, you can see, are everywhere. Okay, there's only joint that excels the hip is the shoulder. And the shoulder actually is a more unstable joint, so it's got a lot more ligaments. But the hip is extremely stable. Okay, this is what the proximal femur looks like. It had this angle can vary. The normal is one right in the middle there. That's what they call the neck shaft angle, provides the best mechanical function, not only for the muscles, but also for the joint itself. And then there are certain outliers where it can be a little bit higher or lower angle. So, and the other important thing is what they call the anteversion to the hip. So if you took a look at your femur from the knee joint, right, I got to stand back here a little bit. You know, from the knee, a fussy thing there. There we go. From the knee joint here, and you go straight up over here, if there was no anteversion, the ball should be right over here. But it's very important that it's offset this way. You can see it again here. If this is the plane of your knee, when it's flexed, you can see the proximal femur has this offset position going upwards. That's very important for normal function. In the child, it's one of the main causes of in-toeing gait, which actually corrects itself most of the time during growth. So by the time you're 8 or 9 years old, that abnormal femoral anteversion improves. Let's just show you the hip extreme. You can go everywhere with the hip. You can see these people that are athletes and stuff like that, and gymnastics and stuff, the kind of stuff they do. That's their hip joint. And ice skaters, you know, when they got their leg all the way, you think about that leg all the way up, 180 degrees from the other side. Phenomenal motion. All right, so there are certain pediatric hip problems that have a problem in adulthood. So I thought it's very appropriate that you understand a little bit about what those problems are. Specifically, there's three main ones. That's what we call developmental dysplasia. Used to be called congenital hip dysplasia. But if you do that, the insurance companies won't pay for your treatment because it's congenital. So now we call it developmental, and we get paid for it. And then there's something called Perthes disease. And finally, those funny letters are slip capital femoral epiphysis. So we'll look at each one of those briefly, but probably the one that's most interesting is dysplasia. So like I said, it was previously called congenital dislocation. The main problem here is that the acetabulum is not formed normally. So it's not typical acetabulum you would see in an adult. You can have a normal hip develop without treatment if the dysplasia is not too bad. So like I said, it's a spectrum. But however, if you get instability of that hip or it starts to want to dislocate, then it becomes painful and arthritic. So a number of things here. There is some hereditary background to it. It's not the typical type of heredity you see, because some generations can be missed. But we know it's there. Possibly there's some hormonal component to it as well. The risk factors for this to occur is all in a female. Female is probably more than 90% are affected with dysplasia compared to males. Don't worry, guys, you got your other problems. So, for some reason, it likes the left hip more than the right hip. Okay, there's sometimes a family history, and if the kid comes out backwards with his tail coming out first, there's a higher incidence of dysplasia than the head first position. So, those things. How was your delivery? Head first? Wonderful. Okay. It's not real common, but it's common enough that it can produce a lot of problems in adulthood. Like I said, it's a spectrum of a condition, okay? It's really not a disease. It's some kind of a mechanical problem that's occurring. So the most severe would be you're born with your hip dislocated, okay? And then it could be anything less than that. So you can have your hip dislocated, but easily reduced, you know, by the pediatric surgeon right after delivery. They check that. It can remain stable, but as time goes on, what's called subluxation means that once it tries to move itself out of the acetabulum, because the common denominator is the acetabulum, instead of being flat, where the head hits up against it, it's like a ski slope. And depending on how severe that ski slope is how soon you get symptoms, okay? And then, yeah, like I said, you can have just a mild amount of dysplasia and probably get along quite well. But we always wonder, the female that comes in with an arthritic hip at the age of 40, a lot of times this is dysplasia that they have, okay? Because we see a lot of them that's when they start having their symptoms, okay, with mild dysplasia. If you have severe dysplasia, you're probably going to develop symptoms as early as your early 20s or so, maybe even in your teenage years. So, and like I said, the slope can be so bad that the hip actually slides all the way out the socket. So the denominator is that the socket is very shallow, and it opens up more than it would normally be. So it makes it an unstable type of situation. And there's a certain amount of deficiency to the socket, so it just doesn't capture that head very well. Other problems are that the capsule itself, that's that strong lining, starts to become lax as time goes on. And also there's soft tissues in the acetabulum or the socket that can cause a problem. So we'll try and show you that. Well, this is what your pediatrician will do right after the kid comes out, okay? So you're going to look for three things that could be a dislocated hip. So as you see over here, right there. Yeah, I'll go back one more. So here you can kind of see this pointer down the area. You can see the crease of the knees look different, okay? Two creases here, only one over there, okay? You look at the knees flexed up, it's hard to picture that in there, but one leg looks a little bit shorter than the other. when you push their knees together and flex their hips. And finally, you can't turn the hip out as much on the dislocated, because see over here. See over here, this is an affected hip. And this is a position called abduction, where you turn it out that way. And you can see the normal side, you can turn it almost 90 degrees out, but the other side you can't. It kind of blocks, okay? So that hip is dislocated. Now the pediatrician can also test that hip right at birth there to see if he can reduce it, pop it in and out, to see how stable it is as far as treatment is concerned. So usually the early treatment, if you can reduce the hip and keep it in a stable position as an infant, they'll go into something called like a Pavlik harness that keeps their legs in that position, okay? They'll either have that or they'll have like triple diapers and stuff like that, whatever to keep the legs spread apart. The whole idea is that when you take an x-ray, you want to be able to see that the hip is pointing directly into the socket. And it's very hard to do these x-rays because most of the time the ball part of the hip is still cartilage. It's not bone yet, so you don't even see it. All you see is kind of where the hip is pointing. You don't actually see the ball sometimes until 8 months, okay? And if it's dislocated, it's usually delayed, so it may not show for well over a year or so. Okay, the whole goal of treatment is to make sure you keep the hip in the socket. That's the most important thing, so it can develop normally. So sometimes you have to operate on the femur part, but most of the time you have to operate on the acetabulum itself. So here's a dislocated hip now, congenital dislocated. You see it on the right over here. You see the socket, and the ball is way out of the socket and pushed. And you can see the ligaments are all stretched out and everything. So the goal now is to be able to get that back into here. If you can manipulate that gently into place, and I say to the orthopedic guy has to do it very gently because he can cause a death of the head of the bone if he's too vigorous with that. That's a big problem. So you got to do it very gently. If you can't do it, you got to open the hip up. You got to surgically get it back into position and then hold it over there, usually with casting, and then watch very carefully to see that the socket develops normally. If the socket is not developing normally, you have to improve the coverage, okay? So possibly at the age of 4 or so, if the socket is still sloped, the orthopedic surgeon will go in there and he'll cut the rim of it and turn it up over the head and then put a kind of a graft in there. So he's made a deeper socket by doing that osteotomy. So look at this. So here's the 2-year-old, okay? He's got all the signs of a dislocated hip. Look over here. You can't even see the ball here yet, okay? Here you can see the ball. So there's a difference in the development of each hip, actually. The important thing here is look at the acetabulum. It's sloping. See that? It's going like a ski slope, going up that way. And this hip already is wanting to slide out along that slope. So after the operation I just showed you, this is how it's redeveloping now. Now you see that the socket has got a coverage all the way around the hip. So you would expect those hips then to develop normally and not have any problems as an adult. Okay, so if it's untreated, you have all these problems that can occur: instability, subluxation, limb length, the pain. Your functional is affected if you're like athletic and so forth. And finally, degenerative arthritis, which you'd like to identify. When a patient comes in that's usually got pain from dysplasia, they say, this is where my pain is. They grab the side of their hip. We call it the C sign. That's exactly where my pain is. It radiates in that area of the C, okay? They don't say it's in my butt. They don't say it's down my leg. They say it's right in that area there. So here is an X-ray. Here is a relatively normally developing hip, okay? This is a 43-year-old, okay? And you look on the other side, and that hip doesn't look quite the same as that, okay? It looks like it slipped out of the socket. I know the X-ray isn't the greatest, but certainly doesn't look the same. So you can draw some of these lines. So if we draw this arc here between the femur and the pelvis, you know, it's kind of just like a nice curved line. If we do the same here, the lines are in different positions, okay? So that further shows how dislocated this hip is. So the ball part should be down here somewhere, not way up there in right field. So now you got a problem that's probably going to be very difficult to treat, especially if there's some arthritis already developed because it's gone too long. This is the examination for dysplasia. The patient has to lay flat on their back with their leg all the way off the table, and the orthopedist is hyperextending the hip and he's rotating it outward. So remember we said that was the unstable area of the hip socket because it's opened up more. So this maneuver is trying to dislocate the hip or push it out of position there. So they don't like that and they get a lot of pain. So this is an operation now that's been developed. We actually do it here in Dayton. This was developed by a Swiss surgeon, very brilliant guy, Reinhold Gans, about 25 years ago, where they completely cut free the hip socket and then rotated it and fixed it back in position so that this hip has now got better coverage of the femoral head. And if you do that operation at an early age when the patient doesn't have hardly any symptoms and good function, you can maybe preserve their hip for their lifetime. So this is one of my patients here. This operation was done on her 20 years ago, okay? So she's already 20 years out. She's probably in her late 50s now or so, maybe a little older. The hip looks worn out. You see there's not much of a joint space, right? It looks like there's hardly anything there, but it's covered, okay? You see the socket covers the hip on both of these views very well. This patient at 20 years has absolutely no pain in her hip. She has totally normal function in her hip, normal range of motion in her hip, and she can do anything she wants to do with her hip. On the other side, the dysplasia was picked up too late. She had a total hip arthroplasty because she was not a candidate for this operation. So she actually had this operation first, even though the other hip was so bad. The quicker you take care of this, the better the possible function is. So at 20 years now, she's just doing phenomenal. You would hope that it'll continue to do that for the next 10 or 20, but we don't know, okay? So these are like borderline cases, but worth a try. Here's a patient that had bilateral, okay? A lot of times dysplasia occurs in both hips, and you can do these operations bilaterally. Again, here's the problem. Late care, you can see the ball looks flattened out. It's sitting kind of outside of the socket. It's shortened. That's an arthritic hip. That's never going to be better unless you replace it. Okay, perfect. Well, there's a lot on that, isn't there? If you have any questions, by the way, you can ask them anytime you want, okay? So any questions about this problem? Okay, good. So the next one is this thing called Perthes disease, okay? And again, this is a relatively more common condition, okay? By common, I don't mean it occurs like 5% of the time or anything like that. It's still pretty rare. But this is where the child's hip, this is usually a condition that occurs from around age 6 to about age 13. And that's where the ball of the hip dies, okay? It becomes avascular and just crumbles down and gets squashed, as you'll see. So here's your normal hip on the right side developing, okay? You can see the nice coverage. Something about this pointer is a nice coverage, okay? See the flat socket is flat here. Beautiful looking, developing nicely. Okay, the socket looks okay over here, but look at this. This whole section over here has just been crushed down like you hit it with a hammer, okay? So now, this will heal itself, okay? This kind of condition goes through a number of stages, and it's going to try to heal itself and become round again, okay? The only way you can stay that way is if you can keep that hip inside the socket will kind of like be a mold for it, okay? If it sits out, it's going to be destroyed. So left like this, it's not covered in the socket. This is a bad sign. Or like this, okay? You can see already some of the problems that you see with Perthes that would be, see how wide the the hip is. The ball part is huge, okay? Not the normal size. You can see it sits way outside of the hip socket, okay? So you can imagine you can't do much with this hip because it's going to hit right up against the hip socket. So that's almost a doomed hip. We call it a hip at risk. So containment of some form is the key. So early containment can be done with braces and stuff like that. Later containment usually requires an operation. So here's an operation where the proximal part of the femur is tilted into the hip joint to try and improve. But you got to have, it's already got to start to look okay to have that kind of an operation. So it's a nasty disease to have, Perthes, okay? And here's the kind of the final, this is a healed Perthes. Even the interesting thing, even the most normal, I shouldn't say normal, the best treatment provided for a Perthes does not guarantee a normal hip. That's the trouble with this condition. You can still have a bad hip, okay? And here's the problems. You see, the hip is very big, very hard to fit into the socket, and very irregular looking. Enough about that. Now, this is almost like a fracture, but not truly like a fracture, because this is an adolescent disease. So these, and again, now the men outdo the women on this one over here. And a lot of times these are pretty good size kids, like 12, 13 years old, that come into the ER. Many of them come in saying, I can't walk because my knee hurts, okay? And in the past, the ER doctor would examine their knee and say, well, your knee's totally normal. Get an x-ray of it, looks just fine. You must have just kind of a, maybe a sprain or something going on, something like that, okay? Now, almost every emergency room doctor knows when somebody comes in with knee pain, check their hip, okay? Because the hip refers pain down to the knee. So these kids come in there, their hip doesn't hurt them, their knee hurts them. So you got to check their hip, okay? That's true for a lot of hip conditions if somebody's concentrating on the knee only. And again, this is a condition, we call it slipped epiphysis, because here's that, what we call the scoop of ice cream right there. That's supposed to be sitting on top of the cone right over here. But you can see it's all the way backwards here, and now you got this big bump. So if it heals like that, that hip's not going to move normally, okay? You won't be able to spread your leg apart. You won't be able to rotate it. It's going to become arthritic. Here's a mild slip, okay? This is a rather severe, and this is a mild, but this also can be a problem when it comes to trying to have normal range of motion. Okay, treatment is you have to stabilize that area so it doesn't slip anymore, okay? You can do it with some screws for a mild one, otherwise you got to do osteotomies and so forth. So, all right, enough about that, because everybody here is adults, it looks like, so we talk about adult hip problems. So most people come in and say, my hip hurts, or, I can't run anymore, or I have difficulty getting dressed in the morning. It doesn't necessarily hip, I just, something about it isn't right, or, it's always stiff feeling to me, okay? So these are the usual symptoms, okay? Hip pain has a lot of causes, okay? Can you imagine? We've got to kind of look at all these things here. So obviously arthritis is one of the big things nowadays, and that could be osteo or rheumatoid, completely two different types of arthritis. It could be a form of tendonitis or bursitis, just a muscle strain. You can have some kind of a malignant tumor or a metastatic tumor causing pain. Again, avascular necrosis in the adult can occur for no reason at all. So, and now we have something that's called femoral acetabular impingement. In the past, we described those hips looking like the handle of a pistol grip deformity, because we didn't realize exactly what was going on. But those kind of hips are actually femoral acetabular impingement, and they can produce pretty significant arthritis quickly. So you kind of look at that first. So there's some kind of aberrant morphology of the proximal femur that causes, as the hip comes up into the socket in motion, causes it to get caught, or it has to be pushed into the socket. And because of that extra force, it produces a lot of damage to the hip socket. So there's actually two types, well, there's three really. There's what we call a cam impingement, and anybody that knows automobiles know what a cam thing is for your pistons. There's a pincer thing, and any military people know that a pincer maneuver is to enclose the enemy from either side, and a combination of the two can occur. So what happens over here, the top diagrams show you a cam impingement. So what we have is this kind of, right here, we don't have a curvature like we have here. So on a normal hip, you should have a kind of a curvature just below the ball, but here we got a bump. So as that hip comes up in flexion, that bump hits against the socket, it destroys the labrum, that's that cartilage I told you about, and then starts to destroy the hip joint itself. And because of that bump, the femur gets pushed backwards in the socket, so it also affects the back part of it. And then the pincer one, the pincer means just the socket is so deep that when the hip comes up, the problem occurs at the neck area. You can see here, this is the offset I'm talking about. See the curvature? That's not there on this one. But the socket here is real deep. So if we have a real deep socket and that hip comes up, it just hits against the socket that way. So it's just a little higher up, hard to see, but you can see this hump. Here's this hump right over here. And to this day, we still don't know how that hump develops. Does it come first? Is it a secondary thing? We don't know that yet. But if we can trim that hump down and there's no arthritic changes, as you see here, it was trimmed down, okay? So now it'll clear. And a lot of times that was done with an open dislocation of the hip, but now arthroscopists are trimming this bone out here, and you can possibly save the hip joint by clearing that area out. So if you pick it up early enough, you can salvage a hip with it. Again, these are young people generally that have this. These come in, the main symptoms is right in their crotch, okay? Right about where their testicle is. That's where it hurts, okay? That's typical of joint pain for the hip. Comes on gradually. It's not a sudden thing or anything like that. And they notice that prolonged walking and stuff like that affect them. And certain kinds of activities it's found in. So like hockey players are prone to having this impingement syndrome. Hurdlers are because you have to get your leg up so high to hurdle. You wonder about the figure skaters that have their leg way up in the air when they do that twist and stuff like that. That's all things that could cause impingement in there. So again, the test for it is a person's laying on their back, you bend their hip up to about 90 degrees, and you try to internally rotate. That means you take the foot one way and push the leg the other way, and the person goes, stop, okay? Because that's impingent now. That's how the hip impinges in the socket. Now you can test for posterior impingement, again, by hyperextending and turning the hip out, similar to the dysplasia one. As far as non-surgical treatment, if it's mild, you might try arthritis medication or activity modification. Physical therapy generally is not the way to treat impingement. Operative treatment is probably the most significant advance that we've had in hip surgery for this problem. In the past, we used to do it always by dislocating the hip, called a surgical dislocation, because you can see everything. You can see the socket, you can see the ball part, you can trim it up and everything. Now the sports medicine guys got a hold of the arthroscope of the hip, so they're scoping hips like you wouldn't believe. Whether that's good or bad, I don't know. I think it's probably bad. The big problem with trimming the bump off is it's inadequate, okay? Because the real problem is in the socket. Because of that thing impinging every time you move your leg, and you think about how many times in a day you might sit down, get up, maneuver like that, okay? It's a lot of times. So what happens, that cartilage, the articular cartilage, right underneath the superior, the upper part of the socket, starts to separate. Like a linoleum, you put a linoleum thing on your floor, and you see sometimes at the edge it separates, starts peeling up. Well, that's what happens in the hip over there. When that happens, the hip is doomed, okay? There's no way to solve it. So you got to be careful, because you can go through a big operation and 1 year later need an artificial joint. It's a nasty, nasty condition. So here again, diagrammatically, you see quite prominent bump right here. Okay, because you can imagine that hip coming out this way, that thing gets jammed in here. Obviously, operation, you see the staples, and it's been trimmed down. Here's a situation where that operation won't help one bit, okay? You got the bump. The bump right there, the hip's arthritic already. So the hip's arthritic. Okay, could be, this is a pincer maybe. You can see how deep seated it is. But when you got this, it's goner. So you don't have a reconstructive operation. You got a salvage arthroplasty operation. This is real common. People come in all the time saying the side of my hip hurts and stuff like that. What exactly is going on? Because sometimes we just give them injections and they feel better. So all of a sudden we realize that all these muscles around the hip, you can have some small tears like you would do in tennis elbow and stuff like that, are very painful and do respond to treatment. So we now have a number of different muscles that can have these tears. The gluteus, the muscles of the hip are called gluteus, okay, with a G, big name. And the huge muscle is the maximus, okay, just like it sounds. And the smallest one is the minimus. And the in-between guy is the medius. So you got three muscles around your hip that basically support your hip. And the tears usually occur in the medius and the minimus when you find them. The biggest danger is they keep injecting these people with steroids every 3 months or so to get rid of pain, because the tears get worse, they get destroyed, and they're harder to take care of. It's also been titled now Greater Trochanteric Pain Syndrome, the rotator cuff of the hip, another terminology being used for it. So a lot of problems. Usually ambulation, laying on the side of your hip, getting up, walking, getting into an automobile, getting up out of a chair, usually are all symptomatic. They produce pain. And again, if you press directly over the hump of your hip, that's that trochanter, you're painful. And if you try to spread your leg out against resistance, it's hard to do because it increases the pain. So that's how we diagnose it a lot of times. A lot of times we get an MRI to diagnose it. So these are all the burses around the hip, okay? So this would be the gluteus maximus muscle. That's the big one that goes all the way down to your knee, and it's got a bursa right there. This is the minimus, and it's got a bursa right next to the trochanter. And this is the minimus, which also has a small little bursa. So to help diagnosis, oftentimes, well, are we going the right way? Yeah. We'll get an MRI. Okay, so an MRI, I'll learn how to use this by the time we're done, okay? Just play with me, okay? It's nice to have just two things. Anyway, that arrow right there and all that whiteness is fluid. And this is what's left of the tendon that should be attaching down there. So this whole gluteus minimus tendon has been destroyed and now has to have some kind of reconstructive operation to repair it. Sometimes you can pull it down and repair it into the bone. Other times you got to transfer the big muscle into the bone, but it's a major operation to do. Okay, we'll skip that. We'll not say too much about this, although it's a fancy name, huh? Coxasultan sounds like it ought to be in Turkey. Okay, it's a snapping hip syndrome, okay? Your hip can snap on the outside from that fascia that lines along it, from the inside, from a tendon there, or intra-articularly because of a loose body, all different places. So this is, so the lateral one is called the gluteus maximus and the iliotibial tract. They call it the iliotibial tract syndrome, actually. And when you flex and extend your knee, if it's really bad, you can actually see your skin and you're thin. You can see everything pop back and forth. Like, it's quite impressive to see that. Just the whole thing gets kind of popped like it's going over a hump and then back again. The same thing happens for the internal one, although the hump is over here on the pelvis. So there's an area here where there is an enlargement of the pelvis, and that if it's large enough, then this tendon here, that's your main hip flexor, that can slide over that bump and produce an internal snapping. And finally, if you have something in your joint, you can get that. So a lot of this is treated all by therapy and very rarely by operation. So we'll skip all these operations. We talked a bit about avascular necrosis, okay? Look at, this is your handout. You got all this stuff anyway. Look at all the different kind of causes that can lead to avascular necrosis in the adult. A whole bunch. This is a very common thing we see now, avascular necrosis. It's probably taken the place of rheumatoid arthritis as far as a degenerative change in the hip. Because now with all these new drugs for the rheumatoid, we hardly operate anymore on rheumatoid arthritis because they all do okay with these medicines, you know. So we have to have something else. Here it is, avascular necrosis. It's again a staged condition, okay? So here's a very simple 4-stage condition. The patient comes in complaining of their hip pain, typical hip pain. X-ray looks totally normal. So why are they hurting? So you try to figure it out, see, but a regular X-ray looks perfectly normal. If they come back in 3 months and they're still hurting, you might start to see some slight changes in the ball part of the hip that should tip you off that maybe this is what's going on. If you wait too long, then what happens is, see, this area here is dead. So if you wait too long, all of a sudden that dead area collapses down into the bone like a ping pong ball. You know, you put your thumb in a ping pong ball, it doesn't come back up again. It's a big divot. So now all of a sudden you got an incongruous area of your joint and you end up with arthritis as a result of that. Okay, so nowadays a very common form of arthritis. The goal is to pick it up between the first 2 stages. The only way to pick it up in the first stage is an MRI. The MRI will show it in stage 1, and this is a stage 1. Hips look perfectly normal, no abnormalities to them. So an MRI, if AVN is there, MRI would show it. Oh, here's your MRI. Well, you know about that. You see the problem right here? It's right there in that weight-bearing area of the hip, okay, on both sides. So AVN is present on both sides, probably to about the same extent. And the big key now is to try to do something to prevent that bone from collapsing down into itself. And here it started to do that. Okay, there's a little bit of an offset. You see that? Just a tiny offset. Over here, there's a bit of an offset occurring here where it's crunched down. So it's already in the later stages. No obvious. This is a gimme right here. You can see it, the change right there. It's very easy to pick up. So that hip right now needs a total hip, not any preserving operation. It won't help it. None that we have anyway at the present time. So at one time, these vascularized fibulas were put into the, a hole was bored through the head and neck area up to where the problem was here. And a fella at Duke University made a big living of taking part of your fibula with the blood vessels attached and drilling a hole in here and inserting that to hold up the bone, okay? Some of them worked out okay, but majority of them did not do well. But you can see it was done on both sides here. Currently now, this is what we call core decompression. By opening that bone up, you decrease the pressure in the vascular system, which is causing one of the problems. And then you can support it. This is what's called a tantalum device. It's a certain kind of metal, very porous metal. And it's used there, and it's got to be specifically put where the defect is going to be. So it's very careful. It has to be located right in this area, not over here someplace, and the same way over there. And that gives you maybe a 50-50 chance of saving a hip. Okay, total hip, you can do all different. We don't usually fuse hips anymore, but occasionally a very young person who would do that. So this a few old slides of after AVN. This was just a simple hip resurfacing. Just a cap was put on. Here's a hemiarthroplasty, okay, because there's no socket, it's all ball with something cemented into the bone. So that's old-time treatment. All right, let's go on to hip arthritis. A lot of you are interested in that. Either osteoarthritis, obviously, is the most common. Rheumatoid is part of what's called inflammatory. It's a systemic disease, okay? So not just your hip is involved, but other joints are involved. Your muscles are involved. Your soft tissues are involved. So it's a form of an autoimmune disease. The other ones that act just like it are ankylosing spondylitis for your back, and a very severe condition where your back becomes so stiff you can't bend over. And lupus, systemic lupus erythematosus, is another one of these conditions that will produce hip arthritis. So those are the three main inflammatory types of arthritis, and they are totally different than osteo. So, osteo produces more bone around the hip to make it strong. All the other ones take bone away because one of their problems is vascularity is affected in order to try to control the inflammation. So fortunately, we don't have to treat too much with that anymore. Again, you can see all the causes that we talked about, okay? You can see right on there, subcapitofemoral epiphysis, developmental hip disease, herpes, all those things in the kid could end up in the adult too. You know, this, everybody talks about this last one, you know, obesity. All right, well, I'm obese too. Everybody think, well, your joints are going to do a hell of a lot worse if you're heavy. But I just got done telling you earlier that your hip, a normal hip, can take 6,000 pounds of compressive force without any problem. Okay. Well, nobody weighs 6,000 pounds. You know, nobody. I don't care what you say. Nobody is that. So your joints are very, very good. The problem with obesity is the morbidities that are associated with it if you have an operation. So things like difficulty with wound healing, difficulty with exposure, and all those kind of things. So it makes an operation very difficult, is what I'm telling you, and you always have a higher incidence of complications because of that. And the whole idea is to try to cut the complications down. So we won't talk enough about that because I got to eat supper yet. Okay, again, it's very slowly progressive. Same symptoms: pain, stiffness, limp. A lot of patients come in, they can't get their shoe and sock on anymore on one side. They just can't get down there to bend over and pull it up, and they start getting something to grab their leg and pull it up and stuff. A very typical thing. They can only walk half a block where they used to be able to walk 2 blocks, and they got to rest for a while. It has a lot of night pain. They can't sleep well during the night. They constantly wake up because their hip is hurting them and stuff. So these are what they present, the kind of symptoms. This is a crazy diagrammatic slide, but you've seen enough of this arthritis and you will that the hip just doesn't look smooth anymore. So it affects both sides. And there's no question here. Take a look at this. That's the joint space, okay? That area there, because the white and the white are the bone. So it's not totally normal, but there's no arthritic changes. It's fairly round. And you come over to the other side, and wow, it looks like kind of like Swiss cheese or something. You don't even know where the joint is. And you got all these things that look like black spots in there, black holes. Oh, those are actually cysts that are in the head because the bone gets so loaded by stress that it just deteriorates and becomes cystic. So there's no question about that's what you would call end-stage arthritis. Only treatment for that is a replacement. And again, see the one on the right? Absolutely horrible looking. The one on the left, still some joint brace is present, so really not ready for a surgery. All right, so you can do some non-surgical things, you know, like you change your activities, lose some weight. Weight is important because for every pound you lose, you decrease 6 pounds of force on your hip joint. So it's a pretty good deal. If you lose 10 pounds, it's all of a sudden 60 pounds less force on your hip joint. Using a cane. Well, I'll tell you, you see the cane? The cane is the greatest thing for a person to have is a cane. Okay, it's your better than your dog. Okay, the cane. And you use it on the opposite side of your arthritic hip, and you can all of a sudden do more, walk farther, have less pain. Trouble is, people don't like a cane for some reason. Yeah. But now you can get all kinds of fancy canes, and you know, molded, all colored different colors. Hurricane, this and that one, stuff like that. The greatest device prior to having an operation, okay? But you see that cane in the opposite side, 30% decrease in the joint compressive force just by using that cane. It's all a deal of muscle balance, okay? Well, now we come to the Detroit part of the, okay. So far we haven't visited Detroit because now we got to get some artificial things in here. So total hip implant basically has 4 parts to it, okay. Obviously there's a stem that goes down into the femur, we'll show you. There's the ball part, there's the cup, and then there's a thing that supports the cup. So here's some diagrammatic changes. Most hips being done now are what we call press fit without cement. So this is a typical press fit stem. You have a ball that fits on top of that, pounded onto there. You have a shell that supports this plastic liner. So almost all total hip replacements now, primary ones, have those 4 parts. What are the differences? The stem sometimes is titanium. Other times it's a very strong alloy of cobalt and chrome. Very, very strong. Doesn't break very easily. Head is usually a cobalt chrome alloy, but now we have ceramic heads, okay? And the ceramic head is wonderful because it's so smooth, there's no wear that occurs, okay? Then you have a socket. For the majority of the time, that socket is a very strong plastic. I mean, you see it in industry all the time, all kinds of gears could be made out of plastic. That is very, very strong, but it still has some problems. It could actually break and things like that. The socket generally is cobalt chrome, and that's just pressed into your bone and anchored that way. So you don't have any real cement being done. So the changes that are present nowadays, or what you look at, or maybe what you should ask your surgeon is, you know, what kind of hip am I going to get? And the main question is, what's the articulation of the hip going to be? So we can have metal on plastic, most common thing, metal on plastic. We can have ceramic ball on a plastic socket. That's the other, probably 95% of the hips put in now is one or the other of those 2 things. We can have ceramic against ceramic. So you can actually have the socket, instead of plastic, it's made out of ceramic. Very good. It hardly ever wears out, but it's very difficult to put in, and the surgeon has to be really good when he does that operation to make sure that nothing happens. Because if the ceramic breaks, it's hard to break, but if it does, then you got a lot of problems. It only breaks if it's put in wrong. And then you finally got metal on metal. Well, now, for a while there in the past, every time you turned your TV set on, you saw bad drug is a total hip replacement. Okay. Now anything that you can get in a pharmacy is a bad drug. You know, blood thinners, that one, this one. So what happened there with that? So it all stemmed from one type of design, which was a hip resurfacing design developed by the Stryker, I believe it was the Stryker company. That was an engineering problem that they didn't do a very good job on with clearances and top, because you got metal on metal. These are what's called hard surfaces. Metal on plastic is called a soft surface. Okay, so it'll somewhat deform to the metal part. But when you got metal on metal and the clearances aren't right, then the metal just starts coming off in little tiny ions. Okay, and sometimes you have these floating all over your body, but mainly around your hip. So all of a sudden it caused a lot of hip problems and actually caused some kind of masses around the hip and so forth. So the people that study these registries, you know, where like Australia has a joint registry. Every hip put in is registered in this computerized program. Sweden has a joint registry. The UK has a joint registry. We're working on it now, but we got a long way to go because we got 300 million people in this country. That's a hell of a lot of people that could have to be in a joint registry in order to study how these things turn out. So they saw that this hip, this resurfacing hip, was failing at a higher rate than any of the other kind of components that were being put in. So that led them to, you know, try to analyze, well, why is this hip failing so much? So they ended up realizing it's a design problem. The company was very good. They said anybody that was symptomatic that required an operation, they would pay for it completely. Not everybody was symptomatic. There were ways to test if they were going to have a problem. But of course, once the attorneys got to it, then it really caused a problem. So this day and age, metal on metal is almost not heard of anymore, except one situation. And there's a certain type of hip resurfacing operation, actually 2, that are designed very well. one from England called the Birmingham hip resurfacing, and the other one in this country called the Conserve, okay, that are still, the Birmingham is still available. The company stopped making the Conserve even though it functioned just fine. So we do want it, and we do it here in Dayton too. So it's kind of like a conserving operation. All right, well, we talked about the meadows, talked about the type of replacements. Here's an early on hip resurfacing, just a ball, okay? So this generally doesn't do well over time because most of the patients are young and the socket will wear out and it'll have to be changed. So that's not necessarily, it was a temporary thing before the hip resurfacings came along. This is a Birmingham hip resurfacing. So now you see that there's two different, right over here is the end of the metal socket, and then inside of that is the ball part. So it's ball against metal against metal. And this hip now has reached way past the 20-year mark for survivorship. It's not associated with any of these adverse reactions that the other metal-on-metal total joints were present. The only problem, it's got a bad name because it's metal-on-metal. That's why it's bad. But we put them in, and we're very happy to put them in. Usually they're in males, younger males with a certain anatomy, do just fine with that. This is what a total hip would look like that's cemented. Okay, so if you look down this stem, you see it's all white down there. That's all cement. Okay, this stem has been in here 20 years. Hasn't changed one bit. The hip socket is in there 20 years. You notice here, it's a little lighter looking. That's a ceramic head. Doesn't look quite as dense as a metal one. So that brings us to this longevity, you know. Everybody went, oh, how long is my hip going to last? You wouldn't believe how many people come and see me and say, oh, the doctor said I'd get 5 years out of my hip. Well, I wouldn't, there no way in the world I'd go and get an operation that would only give me 5 years of relief. You got to be crazy to do 5 years. That's nothing. I want something long term and stuff like that. So, you know, I tell my patients, I expect if you behave yourself, 20 years, get your longevity of your hip, okay, and certainly can reach that. And now we're actually looking, you know, there's hip past the 20-year mark, a lot of it past, so starting to look onto the 30-year mark. So we still don't know what the final thing will be. And maybe one of these days we'll have a diamond hip in place, because diamonds are very hard, very smooth, never wear out. Or we may have a gold-plated hip, same thing. No friction, extremely good surface areas, but a lot of money, which we don't have anymore. So this guy had this hip, he had a hip fracture, or he had an acetabular fracture. That's why he's got all these screws all over the place like that. And he had this hip put in over 20 years ago, a young guy, okay. It's uncemented hip, okay, was functioning just fine, really didn't have much pain, and you got to really study it carefully to realize that here's the ball part. There was less space to the socket above than there was below. So the plastic was wearing out in the hip, and the ball was sliding up. So when that happens, all this plastic material starts floating around your joint, gets into the bone, causes the bone to become cystic and destroyed, and you all of a sudden are in a bad situation. So as soon as you can see that this is occurring, it's time to change. So he had a revision maybe about a year ago. So same stem is still in place, no problem with the stem, but now he has a different kind of socket, different kind of ball, and a different kind of plastic put in. Okay, what time is it? Maybe we'll stop. We still got, are we over time, Amy?
No, we're good.
You're all right?
Yeah.
No questions yet? I'm that good? Put it on your evaluation, okay? Hip fracture, okay? So we've been to the womb, okay? Now we're coming to the tomb, unfortunately. So there's always a classification to everything, okay? So hip fractures can be in different locations, which I'll show you. But the most important part, they usually occur in elderly people. And for many times, this is seminal. You know, seminal means shouldn't happen, the end, terminal. So 1/3 of these people most likely in many studies are dead at the end of 1 year. So if you're old and you fracture your hip, you're way behind the 8 ball, okay, for what can happen. Because a lot of the patients aren't very healthy when they break their hips. So all that kind of stuff has to be taken into consideration. So, boy, you don't want to break your hip after 60, okay? So you can have a fracture that occurs like you see over here, way on the left, what we call a trochanteric fracture. You can have one below all that. This is one over here is one of the hardest ones to have a good reason. Unfortunately, there we go. As a bad actor. Femoral neck fractures in women are the most common things compared to the other type of fractures that are present in men. And you can see that's in your hand now, okay? And depending on what kind of studies you look at, 1 year mortality, some 14% must be really good people, healthy people. The other one, 36%. This is a femoral neck fracture, okay? Again, you kind of look at the scoop of ice cream on top of the cone, and you see it's different. So here's a fracture right here, going through there, and that part been tilted down and jammed into the neck part, okay? So that's why the ball looks like it's way up over here instead of over here, okay? Femoral neck fracture, very common. Again, you can pick them up on MRIs if you're not sure about it. Patient comes in, their hip hurts, the x-rays look just fine, you get an MRI. This fracture here is a little bit farther down than the femoral neck fracture. So this is now called a per-troch fracture. It's between the greater and lesser trochanter. Different type of treatment for it. So each one of these has a different type of treatment. Again, this femoral neck again is associated. This is the worst one, just below the lesser trochanter. A fracture through the femur there. You don't like that. And then now we have this thing. I thought it was good to bring this up right now because it's current. What's called atypical femoral shaft fracture. So listen, your doctors when you get older, they put you on something called bisphosphonates. That's Fosamax, Boniva. You've heard of all these kind of drugs, okay? Now you've heard that. Don't stay on those drugs. You got to get off of them. So that's bad. There's a good and a bad to all this, okay? The bisphosphonates have been a significant advance to decrease the number of hip fractures in the elderly if they're taking it, okay? It's tremendous compared to the few fractures that occur because they've been on the bisphosphonates. And sometimes this atypical fracture even occurs without them being on the bisphosphonates. So now the recommendations, okay? So you can tell all your doctors, your family doctors. Bisphosphonates, 5 years, okay. 1 year off, then restart again, okay? But not to stop them completely, because all of a sudden there's going to be a hailstorm of femoral fractures because of that. It's a really good drug. And this is something we just picked up kind of serendipity. So now we start seeing this. See, this patient doesn't have any fracture or anything. Comes in, maybe has a little pain. But look at this over here and show. See, something don't look right there, huh? It's supposed to look just like this, but now it looks like there's a little bit of a hump. Here's a little bit of a hump, okay? A typical finding, okay? You shouldn't have that over there. That's probably some form of a stress phenomenon occurring. The bone is trying to support it by putting more bone down, but can't quite make it. So what happens, you get this typical fracture. All of a sudden, you can just be walking along. So there it goes, okay? So it's very typical. It's kind of like straight across. It's right where that little hump was, right over there. And it usually has this little kind of spot, very typical appearing thing. So this is happening, but again, it doesn't happen that often. Okay, management. Well, all these things are important. Look at your handout for that. Treatment options, okay, go from internal fixation to partial hip replacements to total hip replacements. A femoral neck fracture is typically treated like this: 3 or 4 screws. Okay, if it's displaced and has to be realigned, you have to do that, and you can treat it with a device like this, which is called a hip screw. So it attaches to the femur there as well as goes up this way here. And this operation is small incision, maybe like that. That's a fairly larger operation. You can put a prosthesis in there. This is what's called a endoprosthesis. This type actually has a ball that rotates on another ball, okay, to decrease wear. But when you have a bad fracture like this, the circulation is probably gone, and trying to save the bone is worthless. Just replace it with a prosthesis, because that's the option. Realign it and fix it, or just replace it. If you replace it, you can get up the next day and walk on it. If you realign it and fix it, you can't walk on it for maybe 3 months. So you take it. If you're 75 years old, I think I'd rather get up the next day and walk on it. Another device that's come along, this came out of Israel, actually. This is a percutaneous implant. So I put these things in with 2 small incisions that are about 3/4 of an inch, 2 little 3/4 of an inch. And we put this in for the intertroch fractures. Okay, not the femoral neck or not the sub, but the one in between. Works very well, very small incision. They can get up and walk on it the next day. That's how strong it is. And these are different types of prostheses. This is another form that's being done where you put a nail down the bone and another one that comes up into the hip to stabilize it. This is actually kind of it's very frequent because incision's very small and stuff like that. So, but the different ways to treat it: total hip arthroplasty, socket, ball, bipolar, or monopolar endoprosthesis. The main 3 treatments for that. How did we get that in there? Oh, and the hip resurfacing we talked about, but that's not for fractures. We're missing 1 slide here, unfortunately. I wanted to show you that. Amy, we don't have the church slide on there. Huh? You put it at the end? I left some of this stuff off about infection because that's kind of crazy. There it is. So, I've been to Russia about 9 times, okay? Because I went there to learn how to do a specific type of reconstructive surgery that was developed in Russia and stuff. So I had a chance to go there. I've been to a lot of different places in Russia. The main hospital that developed this was in southern Siberia. It was a town that was famous for a tank factory during the war. They made the tanks. And they had a 1,000-bed hospital over there, and everybody was treated basically the same way with these metal rings and pins. You might have seen some of these people walking around with those kind of things on their legs or arms. So it was all developed over there. So I went over there many times, lectured over there, operated over there, learned their techniques and so forth. And this is the main cathedral inside the Kremlin when you walk in, the Assumption. So all these, I guess you'd call them paintings or whatever, on the columns, and you can see in the back all the walls with the different saints and everything on there. Just absolutely incredible to see this stuff. And you go out and you see those domes, what they call the onion domes. They're all gold. They're all plated in gold. I mean, who knows how much they're worth. So if you ever get a chance to go to Russia, go to Russia. I mean, there is so much in Russia, you can't believe it. Artwork and stuff like that, phenomenal. Well, I guess that brings us to the close. So we're all heading to the greens, to the pub there for some Guinness. Is that right? Any questions? You got to have some questions. No questions? Oh yeah, okay. You started out with a question.
I know, lots of questions. I think it's because I'm falling apart. The snapping that you were talking
Yep.
about, was that with the trochanteric bursitis, or what was the snapping?
The thing that causes the snap is the tight band of tissue. Okay, so the gluteus maximus muscle is your biggest muscle on the outside of your hip. Okay, it attaches to the femur in one part, but it also extends down and attaches to your tibia all the way past your knee. But that section that goes down there is just a thick fibrous band. Okay, and if that band is for some reason thickened, then where the trochanter is, it can pop over it. As you flex and extend your hip, it can snap over it.
Can you feel that snapping in your back?
Usually not in your back, but you can. A lot of patients can reproduce it, and you can see it sometimes, and you can feel it, but not always. So. And the internal snapping, that's a tough one to reduplicate.
Okay, and how about kinesiotape? I know that. Do you know about kinesiotape? I mean.
Oh, I think that's the therapists have this thing about strips of stuff going all over your arms and legs and stuff like that.
What do you think of that?
Wow. Listen, if anything helps you, even the slightest, I'm all for it. Okay.
Right.
So I couldn't tell you anything, how effective I thought it is, but the patients that have it on seem to like it. That's good enough for me.
Okay.
But we see that more, like for patients that have joint problems, not so much like total joints. And, I should tell you a total hip replacement is the #1 orthopedic operation as far as function and everything else, restoration of life and so forth. #1. Overall, we do a lot of operations too. Okay, but #1. The knee doesn't even come close to the hip. Okay, acceptance rate of the hip is about anywhere from 95 to 98%. Patients say, yeah, I'm really satisfied. I should have had this done 10 years ago. The knee is about 75%. Wow, that's a big difference. Okay, doesn't mean they wouldn't have their knee operated again, but 1/4 of them, it didn't meet their expectations. So that's one of the things you got to really spend a lot of time with patients is, what are your expectations with this operation? Because some people think you're going to become an athlete if they have an operation. That's not going to happen. So. Yes, sir.
How do you make the decision on which of
the type of components?
Yeah, the components, like if it's ceramic or steel or type.
Well, if the operation is going to be on an odd numbered day, then we use a ceramic. On the even number. No, that's always
in the supply room.
that's always a hard. I like the ceramic on ceramic, okay, because one of the biggest problems with a joint is an articulation and wear. Okay, so in the past that's always been the major thing is wearing of the joint. Now we have such good articulations, including the plastics. The plastics are phenomenal. They've gone already to their 3rd generation of plastics. The trouble is we don't know the effect of the plastic until about 8 years. So what we're putting in now, we don't know what they're going to be like in 5 years from now. They may have all kinds of. This is one of the biggest problems with technology. We change and we put something else in because we think it's going to be better, and they are. They're always better for 6, 7 years or so. Then you start having problems. So, a very prominent hip surgeon out of Southern California. Talked to him one time. He says, "I see the patient 2 weeks after his hip replacement to get his sutures out. And I tell him to come back in 7 years because nothing's going to happen between that 2 weeks and 7 years." Pretty interesting concept. Yeah, but it's always. Sometimes the patient has a hip in already. I basically have 3 different hips I do. Okay, one was developed in Vienna. That's a press-fit hip, but not a biological ingrowth hip. And a certain femoral anatomy works very well, but not other type of, sometimes the anatomy of the femur, not the socket so much, but the femur dictates the type of stem. The other one, which is a very well ingrown thing, that means the bone grows into the prosthesis. And it's like the devil to get out if you had to take it out, because the prosthesis is actually coated with coral. That was developed in France. Very smart people to develop that one. That works very well. Okay, that's called Corail, C-O-R-A-I-L. And then there's the Birmingham hip resurfacing for certain people that's acceptable. So those are my 3 operations. And sometimes, we tell a patient we're gonna put a ceramic hip in you. And at the time we try to impact the ceramic into the metal socket, we just don't get it perfect, and we crack it. Okay, well it's got to come out. Okay, fortunately that same socket will also accept the plastic. So all of a sudden, we change. We tell patients that they're going to have a hip resurfacing. You're scheduled for 2 operations. If we can't do your hip resurfacing, or if something happens during the surgery, that's going to be a problem for you, we're going to switch to a total hip replacement, just so you know. That's how we deal with those kind of things. You always have a plan B, like the football guys do. Yes, sir.
Going back to atypical femur fracture,
Yeah.
were you referring to osteoporosis medication for women?
Yeah, right.
And what was some of the terms you used?
The-
Can you
the-
revisit that a little bit?
The medications, you mean? Well, the general group of them, it's called bisphosphonates.
Okay, I wrote that down.
Yeah.
You said it.
And then there's like Fosamax, there's one you take every day, and there's a different type you would take once a week. There's another one with the A. What's the one with the A? Actonel. Actonel is like a weekly bisphosphonate. Boniva, which you see, what's her name? Susie Runton or whatever, you know, always on that. She calls about Boniva, which is, I think, once a month. If you're really osteoporotic, you know, a lot of these are determined on your DEXA scans. You know, you have that scan to see how osteoporotic your bone actually is. You can get a injectable form where you get injected once a year with a very, very strong bisphosphonate that'll last for the year. Right offhand, I can't think of the name of it, but there's all different types.
So you were saying overall this is not good to take 5 years on and then 1 year off?
Yeah, the recommendation now by the Orthopaedic Academy, because of these fractures, is that after 5 years, no event occurring, stop it for a year, okay? Because the problem of the bisphosphonates is there's a normal process of bone resorption and bone production, okay? It's like your skin, you know, your skin is constantly flaking off every time you wash, and new skin cells take its place, and so that happens in a lot of your organs. Well, bone undergoes that too. So in osteoporosis, the calcium and phosphorus is being removed from the bone, okay? It's being resorbed for some reason or other, and the body is not capable of replacing it back again, okay? So if you all of a sudden stop the resorption process, it affects the reparative process, and that's why the bone becomes more brittle as time goes on, okay? Because you don't want your bone to be brittle. You want your bone to be strong, but not brittle. So strong means it can take a lot of force, maybe bend a little bit, but be okay. Brittle means it can take a certain amount and all of a sudden just snap, okay?
And calcium, good thing.
Absolutely. Everybody that's easily over 50 probably ought to be on vitamin D, especially up here where the sun hardly shines, you know, once in a while. And if you're lucky, you get out to it. So you got to be on a high, you know, vitamin D3 is a high form of vitamin replacement, not D2. D2 you probably buy off the shelf, but D3 you need a prescription for. You should be on vitamin C, vitamin E. Actually, in the plastic now, we're putting vitamin E in the plastic to help improve its wear properties and stuff. Well, you don't know what the effect is going to be. So far, it looks good, but we're using vitamin E in the plastic.
And calcium.
And calcium, yeah. And the recommended amount of calcium, I forget, 1,000 milligrams or something a day, whatever.
Okay, thank you.
Yeah, you should be on those kind of things. They're trying to improve your bone health, as they say. In the future, you'll probably see more and more stuff called, you know, bone health, okay, that you never heard of before. There's a lot of companies that are specifically just geared. In fact, one of my colleagues who's retired down in Florida now has formed a company called some bone health company or something like that. Has these supplements that people can buy now and stuff like that. So I think they're all worthwhile. Any other questions? I see my wife is falling asleep in the back room. No more questions? Well, thank you all for showing up. A nice group here, and I hope you go away with a little bit of understanding of how complex the hip is and how many things can go wrong with your hip in life.